Hello everyone, my name's Natalia Shafika. Today I'm sharing a presentation that I delivered 1 year ago at the Infectious Diseases and Global Health Seminar Evening at the University of Liverpool. The focus of this presentation is the rise of infectious diseases, lessons learnt from recent outbreaks for the future. This presentation was originally delivered 1 year ago at the seminar evening, and so does not include specific details of the COVID-19 pandemic that is ongoing. However, there are some points of this that may be of interest to some of you. Firstly, let's consider why infectious diseases should be on the global agenda. The last decade has been dominated by infectious disease outbreaks, not only affecting individual nations such as Haiti with the cholera outbreak, but also whole regions as with MERS and internationally with Ebola and Zika. The consequences of such outbreaks can be devastating, not only in an individual scale in terms of survival, but also on a national level, halting development within nations and the economy. This has propelled the threat of infectious diseases from conversation within the scientific community into the world of politics, economists, and the eyes of the general population through the media. Today, I'm going to draw upon 3 core infectious diseases to highlight the importance of public health on a global scale. These will be Ebola, Zika, and the plague. All 3 of these diseases are infectious diseases, zoonotic in origin, that historically affected a localized region and recently resulted in an unprecedented threat in the modern world that required WHO input. Firstly, let's look at Ebola. Prior to the recent epidemic, the Ebola virus was relatively contained rurally, resulting in only a handful of cases. So uncommon that the mysterious disease was not identified for the cause of death in the index case in December 2013. By February 2014, the virus was carried to the capital of Guinea, yet the first alert for this unidentified disease was issued a month later. By this point, the outbreak was rapidly evolving and quickly spreading to neighbouring regions of Liberia and Sierra Leone. With human-to-human transmission through urban, densely populated regions, this quickly became an international crisis. The WHO reported this outbreak to be the largest, most severe, and most complex Ebola epidemic in the nearly 4-decade history of the disease. The number of cases and deaths to date far exceed those from all past outbreaks combined. As you can see circled in blue, the greatest burden of disease and case fatality ratios fell onto the African states. However, management of Ebola allowed for its rapid containment and control in all regions bar the epicenter in Western Africa, Guinea, Liberia, and Sierra Leone, which struggled with the disease for the whole period between 2014 to 2016. Even in 2018, it is clear our work here is incomplete, with the Republic of Congo again battling Ebola. For the first time, a relatively contained infectious disease saw no boundaries, not only entering cities for the first time, but crossing borders and spreading to new countries by symptomatic air travellers. Ebola showed us the potential global threat of infectious diseases, particularly those we previously deemed inconsequential. 2016 marked the year it became a reality. Again, a known contained infectious disease dominated headlines. This time, it was Zika. As Brazil reported the association between the virus and microcephaly, evidence soon appeared across 86 countries. But this time, the risk was far greater. As hundreds of international athletes, reporters and spectators prepared to descend upon Rio, Brazil for the Olympics, global spread was no longer a threat, but a likelihood. Its aftermath left one message. In the modern world that we live in today, interconnected, an infectious disease is no longer bound by geography. Infectious disease management requires a united global public health attitude. And so, by 2017, the plague outbreak in Madagascar may have almost felt like déjà vu for the international community. There are many parallels between the 2014-15 Ebola epidemic and the plague outbreak in terms of context. Again, an infectious disease zoonotic in origin, well contained this time to the large island of Madagascar, spread quickly through a densely populated urban region, aided by an unprepared healthcare system for what was typically considered a rural issue. The outbreak differed considerably from the typical plague season endemic in the rural areas of Madagascar. It differed in terms of time of year when it began to present, as well as the presentation itself. The clinical symptoms of the Madagascar plague outbreak in 2017 were largely pneumonic, which enabled it to go unrecognized for a period of time. I will be using the public health response to the plague outbreak in Madagascar in 2017 as a case study to illustrate lessons we can learn for the future. While some of the strengths and weaknesses may be specific to this disease outbreak itself, many lessons can be related to the management of infectious diseases overall. The national response and the role of external agencies. A central crisis cell was established to coordinate the health response and was co-led by the Ministry of Public Health and the WHO. Within this cell, 5 committees focused on thorough planning and implementation of the shared technical response. These committees enabled a multi-sectoral integrated response by including the Ministries of Water and Hygiene, Education, Population, alongside technical partners and external agencies aiding in the response. The overall strategy in the National Response Plan focused on 4 core pillars: surveillance, case management, community response, social mobilization and communication. Active surveillance. Active surveillance focused on facilitating rapid, accurate laboratory testing with appropriate sensitivity and specificity considering an outbreak setting. In the plague outbreak, rapid bedside tests were distributed alongside the use of laboratory testing of samples to confirm the diagnoses. The aim of bedside testing was to break the chain of infection by starting immediate treatment and isolation of the patient. Case management. Case management was largely led by implementing partners, who drew on the strategies implemented during the Ebola and Zika to act rapidly in a no-regrets response. Protocols were launched for triage and contact tracing in order to reduce transmission and the progression of the disease, whilst medical supplies were distributed for treatment and prevention. However, like during the Ebola outbreak where cases were underestimated, demand outweighed supply as efforts were still not sufficient. The community response. The community response focused directly on infection control, hygiene and sanitation to reduce transmission of the disease. Social communication. Social communication focused on health promotion and community engagement to foster behaviour change. Another key lesson transferred from the Ebola crises was the need for safe and dignified burials, especially as traditional practices risked further spread. Again, these four key principles of surveillance, case management, community response, and social communication demonstrated in Madagascar's outbreak response management are all important areas to consider when strategizing for any infectious disease outbreak. The implementation of strategies within these four areas was not just conducted by the government and ministries within Madagascar themselves, or the WHO, which just provided largely technical advice, but also by active partners, institutions and charities who have tried to depict via their logos on the screen. It is possible to identify weaknesses at each stage of the public health response to the plague in Madagascar. The passive surveillance process of healthcare workers recognizing, diagnosing and reporting infectious cases is important to break the chain of infection early. In 2017, the plague was able to proliferate over a period of time, unabated, as healthcare workers did not recognize it in its changed form. Typically, the plague was presented in rural areas during a plague season and was in the form of the bubonic plague. However, in the outbreak in Madagascar, the plague was presenting in more densely populated regions outside of the normal plague season itself and was also presenting with symptoms of the pneumonic plague. These circumstances also occurred with the Ebola outbreak 4 years previously. In the Ebola outbreak, the index case was not initially identified until retrospectively, when the infection had already been transmitted into the city. Yet this occurs again here. A different disease, a different location, but the core surveillance process failed again. In this context, strengthening healthcare worker awareness and education of the plague would enable them to recognize and adapt to disease changes. A similar recommendation was made in response to the Ebola outbreak, through regular seminars and workshops to keep the workforce up to date on current epidemic response strategies. If we consider the following stage after disease cases are reported, how do we identify the risk of an outbreak from a collection of data? This particular challenge of interpreting datasets is highlighted in the plague outbreak itself. The use of bedside tests followed by laboratory testing could initially be thought to provide a level of rigour and accuracy to case figures. In reality, it produces datasets that are difficult to interpret. If we look at the variations in the case definition and the values in the outbreak in the table, should we consider the suspected cases when deciding if an outbreak has occurred? Or do we remove them from the final dataset? Are these 46% of suspected cases truly plague? Considering the likelihood of a positive feedback loop, as healthcare workers fear missing any cases, patients with a low probability are likely to receive bedside testing. This has the potential to only add to the numbers of suspected cases. To tackle this problem, we need to ensure that we define and narrow the case definition to reflect the true magnitude of the burden without underappreciating its significance or resulting in a spiraling case count. This is true in any infectious disease outbreak context. Public health officers may consider looking beyond basic epidemiological metrics and include mathematical models to evaluate global risk. This was utilized for the Zika virus in 2016 in real time using available data. Finally, implementation of public health policies can be undermined by social barriers. With regard to the plague outbreak, its association with poverty and dirtiness created a stigma and reluctance to accepting treatment. The shame and embarrassment accompanying diagnosis resulted in resistance to active tracing, with survivors dreading healthcare workers' visitors, as their presence marks their home as a plague site. Such connotation will require a long-term health promotion approach, targeting the middle class to highlight the inclusivity of the disease. Similarly, following the Ebola outbreak, a long-term strategy was recommended to address rumours and misinformation whilst building confidence in the health system. Both of these outbreaks, Ebola and the plague, highlight how our public health work is not complete once an outbreak is contained, and in many contexts, there is a need to address and build relations with the community. And so, whilst each of these three infectious disease outbreaks are unique in their clinical presentation, vector transmission, and even countries affected, they highlight the positive strategies we have learnt and can transfer between contexts, as well as the core areas we can prepare and strengthen in anticipation of the next crises. A whole system approach for epidemic preparedness is necessary for the future. Ebola, Zika, and the plague would each benefit from a truly multidisciplinary One Health approach in the post-outbreak setting. This could target the chain of transmission between reservoirs, vectors, and host before human-to-human transmission. Such strategies may focus on sanitation programs or the use of insecticides based on evidence-based recommendations. Furthermore, by exploring the relationship between vectors and hosts, we may be able to understand trends observed and then prevent human infection. These three outbreaks also highlight the need to improve the readiness and capacity of health systems in order to change the focus from being reactive to outbreaks to proactive. We may not know where the next epidemic will begin, who it will affect, or how, or even the type of pathogen. But we can anticipate that disease X will be coming. Such a hypothetical epidemic disease is likely to already exist amongst us, as Ebola, Zika, and the plague do, to be zoonotic in origin, and to be a pathogen we are yet to recognize affects humans. However, we can prepare and strengthen our health systems in preparation for its arrival. Lessons we have learnt in prior outbreaks testing human resilience are vital. The last few months have seen the unprecedented spread of the coronavirus. A pneumonia of unknown cause was detected in Wuhan, China, and was first reported to the WHO country office in China on the 31st of December 2019. The virus that causes COVID-19 is thought to have first jumped from an animal host to humans in Wuhan, China. At first, Most cases were seen within China and among people who had travelled there or the travellers' close contacts. Whilst these cases were concerning, they did not suggest a pandemic at the time because there was no significant spread outside of China. On the 30th of January 2020, the outbreak was declared a public health emergency of international concern by the WHO. By the 11th of March 2020, the WHO declared COVID-19 as a pandemic. The last time the WHO used this term pandemic was in 2009 for the swine flu outbreak. The WHO director stated that this is not just a public health crisis. It is a crisis that will touch every sector. So every sector and every individual must be involved in the fight.